In this interview, Michael Guthrie speaks with Laura Barr and Susie Hughes about their journeys to becoming advanced practitioners and the responsibilities they each hold in their roles. Michael Guthrie is a freelance consultant with extensive experience in healthcare policy and education. He previously served as the Director of Policy and Standards at the Health and Care Professions Council, HCPC, and was the policy lead for advancing practice at Health Education England. Michael has also contributed to developing BAPO's resources on advanced practice.
So I'm joined by Laura Barr and Susie Hughes, who both work at NHS Greater Glasgow and Clyde. Laura is Advanced Orthotic Practitioner and MSK Specialist Team Lead, and Susie is Advanced Orthotic Practitioner and Neuro Specialist Team Lead. So here just to discuss their roles and background as advanced orthotists, how they got there, what their roles look like, and what they see the benefits are. So if I start with you first, Susie, I wonder if you could tell us about your career today and what your advanced practice role entails.
Yeah, so just from the beginning, from
the top.
So I kind of first started working at NHS Greater Glasgow and Clyde in 2007. And obviously I just started beginning working and trying to get myself into MDT kind of clinics. Mainly like stroke ward sessions, MS clinics, AFO specific clinics, the neuro rehabilitation unit sessions. I even dabbled in a bit of diabetes, but then I soon realised I preferred neuro. From then in about 2013, 14-ish, I was offered the opportunity to join the stroke spasticity service in Greater Glasgow and Clyde. Just really kind of being in the right position at the right time, really. And that kind of resulted in being able to get mentored by the stroke consultant in post there at the time. So he was able to kind of mentor me through the botulinum toxin injections and assessments. And from there, I started doing the pharmaceutical company training, which is kind of more specific to botulinum toxin injections. So there was a few of those. So they were kind of like assessments on how to identify patients that require it, the administration of it, and obviously the use of the ultrasound for guided. Kind of roughly around the same time, also interviewed to be the spinal injuries specialist orthotist in there. And then further on to about 2017-18, if I remember right, I became the neurological team lead for the service in Glasgow. So that involves kind of running the neurologist escalation clinics, supporting staff, evaluating new devices, just kind of ensuring that the orthotic service in the neuro area is run efficiently for the health board. Kind of academically, I've kind of completed a few master's modules. I've done a stroke specific one, a leadership one all for Glasgow Uni, and then a jump ship. And I've recently done the clinical investigations at Glasgow Caledonian for advanced practice, and my hope is to start the advanced practice research module at the end of the year. So that's kind of me up to date now.
Great, thank you. And Laura, could you tell us about your background and your role?
Yeah. So I started around about the same time as Susie in NHS Greater Glasgow and Clyde, so 2007 for myself as well. And I focused a bit more heavily in diabetes. So where Susie decided that wasn't for her, I at that point thought that was for me. I did my master's specifically in diabetes, and I really enjoyed those clinics. It was sort of my first real experience of working in an MDT environment and seeing what the different roles were and seeing how we could not just work as an orthotist in that clinic, but to kind of extend into different skills and to work more collaboratively. around about the time that I finished my master's degree, I had started working for the as one of the educators in the MSK course for BAPO. And that had kind of sparked my interest in the field of MSK. So we, as orthotists, I think one of the main roles that we work in is MSK. I think about 90% of orthotists work in that area of clinical practice, and I was very, very interested in that. I started doing a bit of shadowing with orthopedic clinics, getting in touch with orthopedic consultants, and sort of being in the right place at the right time again. I was able to get an extended scope role in orthopedics. They were extended scope roles at the time, and they kind of laterally transitioned to advanced practice roles. So for the past 9 years, I've worked between orthopedics and orthotics for the clinical part of my position. Obviously, with advanced practice, it's not just about the clinical part. That's what everybody asks about when they're interested in your advanced practice role. They all want to know about the clinical side of that. But there's also obviously the other four. There's 4 pillars of practice, so the other 3 as well. Both Susie and myself hold specialist team lead positions, so we have a leadership role as part of our positions in Glasgow and Clyde. And that's quite interesting because we're able to do escalation type clinics where maybe other members of the team or members of other specialities can refer into us specifically for more complex patients, more complex cases, do quite a lot of MDT working with that as well. And over the past few years, I've had more of a focus on research in my role as well. So 3 years ago, I started a PhD and have been doing a bit more research work on that. And as part of that, I've also had a NRS research fellowship, which is running until next year. So it means that I can integrate research a bit more into our department.
Great, thank you. I mean, obviously incredibly far-reaching, both of your roles. What do you, in your view, what do you think the benefits have been to having the advanced orthotist roles? I guess both to how services are delivered, and I know you talked about how you're part of a multidisciplinary team, but also to the patients when you are providing clinical care. Can I start with you, Susie, about what you think the benefits are?
Yeah, for me, like especially like within like spasticity clinics and things like that, it's more just offering the patients a better improved pathway. So where they would previously get added onto waiting lists for different departments and not kind of linked, you would kind of run the risk of either orthotists having to make multiple devices or the spasticity clinic giving injections and then that injection wearing off by the time they then get their orthotic treatment. So there was a lot of wasted appointments, a lot of wasted time, a lot of wasted money and drugs getting used. So even just having the orthotist in there improves that pathway. Plus, you can also then reflect back to like the referring orthotists, whoever refer in, because I would say like the majority of the patients that are in those clinics get orthoses. So I'm able to then reflect back to their like local orthotists to let them know exactly what's going on and when. So it's kind of a good, better coordination, I would say, for the patients. So the patients get the kind of better outcome.
Fantastic. And Laura?
Yeah, I think the same as Susie, there's a real benefit to having any advanced practitioner in these sort of multidisciplinary type roles. It's of advantage to the departments in which you work for the benefit of the patient. When you're working in sort of consultant-led clinics as well, as an advanced practitioner, you're taking some of the onus off of the consultants and able to take up some of that work where patients might maybe end up waiting for longer to see a consultant. They can see one of us who are able to do the assessments or the diagnostics or the treatment or post-operative care or whatever that might be. So it gives a kind of faster pathway to the patients and ultimately provides them with equal care. From the perspective of our team, I think it's beneficial as well because we've mentioned a couple of times the escalation clinics that we run. It allows our team that opportunity to sometimes as a clinician, you have a patient, you've done everything that you can, you don't know what else to do, and you don't maybe know where to send them. The tendency is maybe to send them back to their doctor or to another healthcare practitioner. But within our department, we have that escalation service where our own clinicians can refer in to myself and Susie and our other colleagues, and let us have maybe more of a kind of advanced assessment, advanced treatment pathway for the patient without deferring them out of the service. And we're able to coordinate a bit more because we do have those kind of strong links with consultants from various different specialities as well.
And Laura, you mentioned the 4 pillars of practice, so clinical being one of them, and then leadership and management, education and research. What do you think? I mean, I think you mentioned that often people are most interested in the clinical pillar, and that's what they tend to ask about. What do you think the benefits have been for your service of your mastery of the other pillars? You know, what contribution is your research, your education, your leadership and management capability making towards how services are delivered?
Yeah, I think it's absolutely vital to consider all 4 of the pillars. That is a fundamental part of advanced practice. You have to be working at a certain level within all of those 4 pillars, and they all complement each other. And I think the benefit of having the 4 pillars and being able to work at different levels within those 4 at different times in your career, it means that your advanced practice role, certainly in my experience, and I know in your experience as well, Susie, your role can merge and it can diverge, and you can be doing different things with it. So I was very clinically focused for sort of the first maybe 6 years of my clinical role, of my advanced practice role, and then decided to kind of boost that research pillar and took my role in a different direction without actually changing my role, just changed my focus. And I think there's a lot to be said with that in an advanced practice role, is that you can at different times be working on different pillars. It's a huge benefit certainly to our department. Research is not it's probably the most underdeveloped pillar in prosthetics and orthotics. I think there's agreement across the board about that. So being able to be in a position where I can bring research into our department, it doesn't just benefit our staff, who they get to be involved in research trials, they get to see the outcomes. We're doing the research with our patients, who we get to work with in collaboration throughout. So that's really, really powerful. But also the output of that research at the end of the day can benefit the entire profession. So if we're choosing to look at something specific, a question that we've had clinically for many years, I'm sure other services have had that question as well. Doing research allows us to answer that and then share those findings across the profession. So I think it's very beneficial. And as I say, that's just at the moment, my focus is more on research. The same goes for education pillar. You can be building up an education role, not just within the area that you work, but across the board, across the UK, extending that out to other professions as well. So there's a lot of scope to work within advanced practice.
And Susie's same question for you. Has that been what's your experience of kind of what those other pillars bring to the service and ultimately the care you're providing for patients?
Yeah, I think similar to Laura, obviously, when I first started, it was very clinical heavy, but it's kind of nature of the beast. I think you kind of need to increase that clinical skill, I think, to begin with, and then develop into the others. Certainly I'm not quite as far into the research as Laura, maybe one day. Yeah, I think definitely for the service, having it a wee bit in each pillar and building on them to, like Laura says, you don't need to do the same thing continuously. You can mix and match, whether it's a bit of education, like doing study days, like I've done a spinal study day and things like that, which was open up, which was good for networking and kind of educating staff, and just things like that. And like the use of the escalation clinics definitely in there for education and support and mentoring and clinical skills. Yeah, I think definitely agree with Laura that you need all 4, quite a high standard for the advanced practice.
Right, thank you. I next wanted to turn to any challenges you might have faced in your role. So as you'll know, at the moment, advanced practice is in its relative infancy in the profession overall, and there are some great examples like your roles of innovative ways of using advanced practice to support service delivery, but we know it's not perhaps as well established in perhaps some other larger AHP professions like physiotherapy, for example. What, if any, challenges have you found in your roles? So that could be anything. That could be how you relate to colleague, how you command the confidence of colleagues in the multidisciplinary team, or how you're working with other prosthetists and orthotists in the profession. Just really, yeah, any challenges that you've faced and how you might have overcome them. I'll start with you, Laura.
I think I kind of like to try and look at it positively, where the fact that it is in its relative infancy gives us the advantage of being able to sort of develop and create these roles and push these roles in whatever direction, and to show what is possible. And there's a lot that's possible from these different roles. Susie and I have very different clinical roles, but we've both been able to kind of forge those paths, and it's been challenging, but it's also been quite fun to look at the different avenues that we can take, and to push the boundaries a little bit. So from that respect, I think it's exciting that we're at this point where we can start to look at what's possible. But yes, there are challenges, of course, and I think one of the big ones is because the professions that you will be working with when you take an advanced practice role, they are likely to not have encountered an advanced practice orthotist before. And they don't necessarily know what to expect from you. They don't know what it is specifically that you do. They might expect that you are just the person that fits the shoes. So there can be a bit of a challenge there in educating other professions about what the role is. But we've both, Susie and I, have done that by being a positive example. So we have shown what we can do, and other professions respond to that positively because they see the benefit that they have by having you in the service. So I think, but that's probably one of the greatest challenges, and because these roles are quite unusual at the moment, anyone else who's stepping into the roles just now, you are going to experience some of that, but view it in a positive way. It's a fun challenge.
And Susie, does that reflect your experience as well?
Yeah, definitely. I think, having been like one of the only orthotists, sometimes when you go to like meetings and you're in clinic, it can be kind of challenging, but I think once you kind of show your place and what you can bring and the benefit you can bring, it makes a difference. And like Laura says, like definitely it's a challenge because it's new to us, and it's kind of navigating our way through that, trying to work out the best paths and things, where other bigger disciplines obviously have a lot of these pathways in place for advanced practice. We're fairly new to it. For me though, like I have had probably different challenges to Laura, in the sense that like just life in general, I've had children, I've had mat leave, so I've kind of dipped in and out, jumping back and forth off of leave and things. And obviously with that comes financial as well challenges. So obviously I've got childcare and cost of living, and having to negotiate and navigate like kind of where to find funding and things like that. And to know that like you can, like these funding things are available. And for me, like I was still able to do that in amongst having a young family. So slightly different, but yeah, challenges none the same.
And I wanted to ask you just about a specific challenge that sometimes comes up, and again, it's not specific to prosthetics and orthotics. It does come up in some other health professions as well. So one challenge that sometimes reported is I guess a little bit of frustration sometimes when people will see an advanced practice role that they're really interested in. They'd feel like they can contribute, but they find that it requires the ability to prescribe. And obviously, as you know, at the moment, prosthetists and orthotists can't train to become prescribers. Have you found any challenges around prescribing. I guess that might be others' expectations of you, or it might be because you would like to go into that area. And I guess I wondered whether that's been a challenge or a barrier at all, and how you might have overcome it. And I think, Susie, I know you were talking about medicines that you were involved in giving patients, which I assume was under a patient group direction. So I wondered whether you might be able to start us off with that question.
Yeah, I know that the independent prescribing is definitely a bugbear of mine, Laura's. Yeah, it does cause some restrictions. I mean, obviously, like we can through PGDs we can still obviously prescribe and things like that. But for me, certainly, like with the botulinum toxin and the antispasticity medications, for me to use like the Botox, it's very specific to a specific group, specific muscles. So if you ever assess a patient and it's out with that, I can't do it unless the consultant's in the room. So it just means that if the consultant's on call, or if we're on a ward, it's just myself, the physio who obviously can, independently prescribe, it's over to them. So it's just a bit of a restriction. So it kind of certain posts and things like that, I would imagine, for me anyway, like it puts a restriction to my job that way. So yeah, one day.
And Laura, how about you?
Yes, so I work under PGDs as well. Mine are for steroids and local anaesthetics predominantly. And fortunately, I don't have quite the same challenges that Susie has, because obviously there are more specific guidelines for botulinum toxin. With the various steroids and anaesthetics that we use, the group of patients that I'm seeing tend to fit that criteria more neatly. So I haven't encountered as much of the potential issue of a patient coming in and then me not being able to administer to them. So with the PGDs being able to supply and administer allows us to see that patient group quite comfortably. I haven't had as many of the challenges in my clinics, again, because I'm able to do what's needed at the kind of assessment, diagnostics, treatment stage. The issue that I've always had a bit of a question mark about is if I'm doing post-operative reviews and there's infection, then I can't prescribe antibiotics, where some of my my colleagues, so my advanced practice and podiatry colleagues who are independent prescribers, they can. But that's just a limitation that I'm aware of. I've never actually hit that in clinic yet. But there are barriers to what we're doing. We're limited, and as Susie said, it's something that we're both aware of. We've agreed to be part of any group that's helping to move that agenda forward. But it is obviously that's a complex issue that we have to overcome, as not even just as a profession, but as a group of allied health professions.
Absolutely. I should mention for our viewers that BAPO has just published a short guide to patient group directions, which draws upon examples that I know that you've just talked about in terms of the medicines that you've included in patient group directions, as part of really encouraging the profession, despite the limitations with prescribing, just to make the most of the medicines mechanisms that already do exist, including patient group directions. Given all your experience, what advice would you give? So if you were speaking to a prosthetist and orthotist who, was chomping at the bit to develop their career, wanted to put themselves in a good position to be able to get an advanced practice role, what advice would you give them? And I'll start off with you, Susie.
I think just first and foremost, seek support from your management. Getting that support from your management makes all the difference. Me and Laura are very lucky. Our management is great, very supportive. Network your area of interest as well. Like, see what clinics are out there, see what opportunities are there. Obviously look for courses, funding, see what's available. There's a lot out there that I didn't even realise until you go looking or asking. What resources as well, like say BAPO, there's toolkits, there's advanced practice toolkits with lots of resources and things on them. Like if people are interested, there's lots out there, it's just finding it. Definitely.
And Laura?
Yeah, totally agree. Position yourself to be ready to step in when that role comes up. So don't just wait for a role to come up. You need to be sort of pre-prepared. So with advanced practice, it's very clear that it has to be underpinned by master's level education. It doesn't mean that you need to have a master's degree at the point of taking that role, but you do have to be showing that you have a level of educational ability to work at that level. So scope your area of interest, exactly as Susie said, get an idea of what you're interested in, but also be prepared to maybe compromise on that slightly, because if a role comes up in a sort of adjacent field, be open to that. Don't just immediately say no because it's not the niche that you wanted to work in. So be open, but be aware of what you want and work towards it before that position comes up. And I also just think, as you said, Susie, networking is absolutely vital. That's how both of us ended up in the positions that we are, was through networking, literally knocking on the door of the consultant and saying, can I shadow your clinic? Knocking at the surgical door and saying, can I come and watch you operate? So don't be afraid to put yourself forward, network, decide what you like and work towards it. It's hard work. You do have to put a lot of work in, so don't be afraid to put the work in.
And can I ask you just a specific question just about the education and training that you mentioned there, Laura? So first of all, just to mention that across the UK, advanced practice has developed over time. So people would have followed lots of different routes and pathways into advanced practice roles. And there may be differences, or there are differences between the UK countries now as to what they might expect now for someone to go into an advanced practice role. But in Scotland, Laura, what would be the expectations if you were applying for an advanced practice role? Would you have already completed master's level study, or would you do it whilst you're in the role? How would it work?
I think the expectation at the moment is that you would be working towards it and would have proven that you're working towards it by at least of completing a few modules and proving that you're working at that level. I think they're finally sort of coming towards an agreement across the 4 nations about the definition for advanced practice as well, which is helpful, but it's also quite woolly. And I think it has to be in terms of everything, but that includes the education. But underpinning master's level education seems to be where the standard is sort of across the 4 nations at the moment, but not necessarily having completed at that point.
And would you normally, in Scotland, be that master's level training, would that normally be a master's in advanced practice, or could it be some other kind of master's, relevant master's qualification?
Yeah, they make it quite clear that it can be a relevant master's qualification as well. But the fact that there are now advanced practice specific master's programs, whenever anybody asks me about it, asks my advice, I guide them towards that, because there's a kind of group of modules. You don't have to do a set 6 modules or whatever it may be. You can pick and choose between the modules in that program and kind of pick and mix to make it work for your specific role. So I think that those programs are fantastic. But it doesn't mean to say that if you were working towards a master's that was not specifically advanced practice, it's not to say that that wouldn't be relevant, because as long as it's relevant to the role that you're doing, then it would absolutely be appropriate.
So we just talked a moment ago about what you might say to a post anaesthetist who was wanting to become an advanced practitioner. I wanted now to turn to the employer. So if an employer was asking you, why should I care about advanced practice? What I don't have advanced practice roles currently. What are they going to give me? What would you say to them, Susie?
I think I would tell them, like, think of the long-term benefits. Like, short-term, it might seem like it's maybe not as appealing, because it might mean maybe, reduction in clinics and things like that to allow time for staff to go to like new MDT clinics or things. But just to think of it long-term, like Laura says, it's great for the department when you've got advanced practitioners. Just as for the health board wide, kind of like if you've got somebody at advanced practice level, and obviously like in the long term, it will reduce waste and it will improve patient feedback and patient pathways and the patient treatment. So it's, even though it might not be appealing initially, it would be, well, it would pay off long term.
And Laura, how about you? What would you say the business case is?
Yeah, I'd say that you're putting that kind of resource into your department to build a certain set of clinical skills, leadership skills, education skills, research skills. By doing that, you're providing an opportunity for the rest of the department. So, like we've said, we've got clinics where we can guide kind of patient treatment throughout our department a bit more seamlessly now. It has the benefit on the rest of the staff, because they can come in and shadow those clinics with you. They can learn from someone who's already working at that level. We can provide mentorship to not just staff in our own department, but staff in other departments. It also has really, really helped to build relationships between different departments as well for all of us. It's made orthotics more visible in our health board, and that would be the same for throughout the UK, whatever trust or health board you're working in. The visibility gives you connections, it gives you networking, it gives you opportunities that are not just for that individual person, but opportunities for the wider service. So I think that from that perspective, as Susie said, it might at first involve taking a little bit of resource out of your department from a clinical perspective to allow that person to build skills in other areas, but ultimately those other areas are what's going to make your entire service better.
Thank you. Yeah, so that importance there, I guess, of that kind of longer term view, not a short term one. Be thinking about the medium to longer term future of your service and what that can bring for you and your patients. I've got one final question for you both. So our conversation today is really about understanding your roles in order to inspire prosthetists and orthotists to think about and to make the most of the opportunities for career development, particularly at the advanced level of practice, but also at the enhanced or specialist level of practice before that, and consultant practice afterwards. You both talked about your role. What does the future look like for your careers? Where do you think, sitting where you are now, you might want to go, or where might your advanced practice take you in the future, do you think? Can I start with you, Susie?
Yeah, oh God, I've not thought that far ahead. At the moment, I'm kind of concentrating on getting that, all the master's level qualifications. So and dabbling in each pillar. Like Laura was saying, like the research pillar is usually the one that's very low, and in my case it is. So yeah, that's like kind of my next aim, is to get my foot in the door a wee bit with that, and just continue as is and see what kind of doors open as time goes on, whether it's kind of consultancy posts and things, because we do have HP consultant posts in our health board, and whether something along those lines in the future, because there's stroke consultant HP posts and spinal and major trauma and things like that. So I'll just be on the lookout, but while I'm waiting, I'll be hopefully getting all the level that I need for when it does happen. I can fight with all the physios and OTs to get it.
And Laura, how about you?
Yeah, well, as I've sort of alluded to, I've been kind of more heavily focusing on the research side of things for the past couple of years, and really, really enjoying that. My kind of goal over the next few years is to try and increase the research profile in our department, and ultimately for the profession as well. So I've been looking kind of out with just what I can do in our health board, and looking at what I can do with BAPO and with CAPR, and getting involved in other kind of research, taking other research adjacent opportunities as well, so that the information that I'm able to take in, I can then pass along to the rest of the profession, the rest of our department, and just really try and be part of building that research profile.
Great. Well, thank you so much for your time.
For more information on advanced practice, kindly visit the BAPO website and check out the resource tab, where you will find newly updated assets on advanced, enhanced, and consultant practice.